And since we're all joining, we're going to go ahead and really get started with the meeting to get things going. And so we just have a couple of announcements as the SIG before we introduce our presenter. And as you're all joining here, we would love to hear where people are calling in from today. The SIG reaches people all across the 50 states, as well as sometimes outside of the US. So if you want to enter in your current location, and so state, city, that would be great to hear and see from everyone. And we're so excited for you all to be here. So welcome to the Primary Care Behavioral Health SIG first meeting of 2021. My name is Kelly Bozak, and I am one of the co-chairs this year. And I would like to give a moment to Brittany to introduce herself as well.
Hi, I'm Brittany Houston, and I'm the other co-chair for the next 2 years. So welcome, excited to be with y'all for the first webinar of 2022.
Good. Thanks so much, Brittany. And we have a couple of other SIG leaders who are calling in too. We'll show their faces on the slides as well. So so feel free to reach out to them with any questions as well. For our meeting today, just a couple of notes. Thanks for joining us. Please mute yourself if you haven't already using the green microphone, and feel free to add in where you're calling in from in the chat. Please unmute yourself if you'd like to contribute to or join the conversation. I'll also be monitoring the chat as we go through today. So while Dr. Bailey is presenting, we'll keep an eye out for any questions, and I'll kind of keep those in a parking lot for a time when we have some time to ask questions, and we can follow up with those if we don't get to them. If you're new to us and you don't receive any communication, usually if you're a part of this, if you're a member of CFHA, you should get all of the emails that go out on the Gaggle listserv. Those are all saved in Gaggle as well. But if you do want to connect with us more deeply, you can reach out to our secretary, Samantha Kettle, and her contact information is located on this slide. And then also you can click to join the PCBH SIG through the CFHA website, just to say that you're interested in the special interest group. For today, we're just going to share some welcome announcements and then have our webinar, and if time allows, we'll have some closing minutes together. We are recording today, so we hope to be able to share this with those who could not attend in live. For any job postings and for most recent blogs and the latest news on all things integrated care, you can visit integratedcarenews.com. If you have any job announcements or training opportunities that you would like to share with others on the call today, feel free to add those into the chat as well. And we'd be more than happy to help support those and share those widely with the community. And feel free to send messages to PCBH SIG members through the CFHA Gaggle account. And you can reach out to myself or Brittany or anyone on the leadership team if you want to share any announcements with us. And this is, again, our leadership team for this coming year. It actually should be 2022 to 2023. I'll see it a little bit later, but myself and Brittany as co-chairs, Megan Sundow is our member at large, Samantha Kettle, secretary, Gabriela Gibson-Lopez is our early career professional representative, and Natalie Garza is our student rep again this year. Thanks everyone for your leadership and support. And then our SLIP PCBH group is the Serving Latinx Populations PCBH group. Yahida and Natasha are our leaders this year, and they have an upcoming webinar this Wednesday, which I'll get to in a second, and encourage people to join. For the SIG this year, a couple of announcements. We're going to have membership calls and webinars throughout the year. A formal schedule will be coming out, but we're planning on having 4 meetings throughout the year, plus additional time at the conference. So 4 coming, today is the 5th, and then a few in September and October. And coming to your inbox soon will be a community survey to help us to solidify the topics of interest for webinars and community conversations. SLIP's first meeting of 2022 is this week, this Wednesday at 1 p.m. Eastern Time. The webinar will focus on improving access to health, our experience serving Spanish-speaking families in a pediatric primary care network. This sounds like an excellent opportunity to connect with leaders and thought partners and to have a conversation around care. So feel free to join, and the details were sent out via email earlier today about how to register for that webinar or join on Wednesday. An additional announcement, the CFHA Community Conversations is going to highlight a topic that we're talking about today in our webinar. It's going to be community building around LGBTQIA+ patients in primary care. This came out of conversations that started at the conference last year, and that CFHA wants to continue to move forward and prioritize amongst the community. So save the date for March 1st, 2022 at 12 p.m. Eastern. You can register in advance. Liana just put the link in the chat, and this will be a community building conversation. CFHA is interested in learning what kind of sessions folks would like to see around this topic at the next conference in October, and if there's opportunity for a smaller subgroup to gather to make this a more consistent part of our programming. So please register for that and reach out to Tanya Louder if you have any questions. Thanks for clarifying, Liana. The registration link is for the SLIP meeting on Wednesday. Then today, our webinar will be with Dr. Melissa Bailey, focused on affirmative care for transgender and non-binary clients. Those are all of our announcements for now. When we return at the end, if you aren't able to join us until through the entire webinar, I'll share some of the closing remarks now, and then at the end of our session today. Sessions will be recorded and posted online. We'll send an update to listserv once that's up. Our next meeting date will most likely be March 23rd, 2022, so Wednesday during the lunch hour Eastern Central Time, and then that community conversation in March. If you're interested in being a PCBH mentor, we are continuing to recruit mentors for new and early career professionals and people who are building their leadership skills in PCBH. So if you'd like to receive a mentor or provide mentorship, please fill out this form listed here or contact me to get involved. All right, if you have any questions, feel free to add those into the chat, and I will pass it over to Dr. Bailey.
Hey, everybody. Thanks for having me. I'm excited to talk with you all today. I'm going to share my screen so you can follow along with my PowerPoint. Because I have this up, I likely am not going to be able to see chat pieces when they come up. So if you do have a question, I think somebody said they'd be monitoring the chat. It's also okay at any point to unmute and be like, I have a question, and then we'll see where it is. I tend to like to be pretty discussion interactive in times that I present. Also, I'm aware that we only have an hour. So I'm going to try to not go off on too many tangents and actually get through the main pieces so that way at the end, we've got some time for questions. All right. So here's my intro slide. My name is Melissa Bailey. I'm a clinical psychologist. I use she and her pronouns, and I work at Howard Brown Health, and I'm the Associate Director of Training and Development. And talking about affirmative care for trans and gender expansive, non-binary folks is one of my absolute favorite things to talk about. It is very much a major portion of the clinical work that I do. And I love to help folks find ways to be more affirmative in their work. So this just speaks to the mission statement of Howard Brown, where I work. We're working to eliminate disparities in healthcare experienced by LGBTQ folks through research, education, and services. Here are today's objectives. So looking for ways to increase affirmative care, identify barriers, and then how can we as clinicians support access to legal and medical transition? All right, so before we dive in, everybody I'm sure has some questions at the out front, and that may be why you've come today. So take a minute, write it down. This is one of my favorite kind of check-in things at the very beginning. That's for you to hold on to. And then at the end, when I say, what questions do you have? Sometimes that's the one question you hope to get answered, and then you forget to ask it. So if you already have it down, that's helpful. Another thing to write down is something you already know. What is something you already know to do that's affirming to your clients? Because I think sometimes going through a topic, it's easy to be like, oh my gosh, I've realized there's more that I didn't know, and now I don't feel like I know anything. And so I find it's just helpful for all of us because we all know something. We all know something. So if we start in that place, it just helps also think about where do I add to my knowledge rather than coming from a place of feeling like you don't know anything. All right, so when I think about affirmative care, and my slides say TGNB, so that's transgender non-binary clients. I also will say TGE, which stands for trans and gender expansive clients. I've been kind of loving TGE a little bit more lately because I think it speaks to the broader space that folks may exist in. Because not everybody who's gender expansive identifies as transgender. And there can be folks who are gender expansive who also don't identify as non-binary. So just working on moving to more and more inclusive language. So when we're starting from an affirmative care standpoint, the first thing we want to do is look at where do our own binary assumptions show up and where do they come from? We're going to go over some baseline knowledge of terms, talk about ways to show visibly that you're a supportive and affirming space, and talk about how to improve inclusive language, recognize what self-determination is, and then moving on to the other pieces around medical legal transition. So starting first with some pieces around binary thinking, right? So we all know that we're all raised to kind of categorize in a yes or no perspective, right? Like everything is easier in our brains if it's this or that. And so we're all socialized to think in that way. And that, that really gets reinforced in the space when we're talking about gender and working with our gender expansive clients, because our brains, when we come in, even if we're like, I totally want to be an ally, I want to be affirming, it's also really easy for us to get like stuck in the space where we're like, my brain, it just collapsed on itself. I'm having a hard time seeing outside of these boxes, right? Boy versus girl, peace versus war, good versus evil, yes versus no. And that ends up making it harder for us to show up in affirming ways because our brain is trying to get us to do what we've been conditioned to do, right? So the biggest way that we can start off in trying to be affirming is just challenging our binary thinking, right? The more that we can remember that our brains are doing that because it's an automatic response. It is the way that we have been conditioned and socialized. It can help us break that down, right? And the biggest piece in thinking about binary thinking is, in thinking about good versus bad, right? People who fit into what we've perceived to be good and right are normalized, they're privileged. And folks who are outside of that box end up being much more marginalized, not seen, or even punished, right? So that's the space to work on it. So specific to gender, right? We have to look at our own gender socialization, right? Because the way we've been socialized to understand and demonstrate our own gender shows up in how we interact with other people, right? So one of the ways that I like to think about this is, I think most of us, just in society now, logically believe that all kids can play with all toys, right? If I asked 100 people on the street, walked up and said, hey, if this kid who's a girl that's 6 wants to play with a monster truck, is that okay? I think, 99.9% of people would be like, absolutely. Kids should get to play with all toys. Or, hey, can this boy play dress up? People would say yes. But it's often that like internal response that you notice if you see less so a girl playing with a monster truck, but more a boy playing with dolls, right? There ends up being this like, there's just this like, right? We notice it because it's outside what we're conditioned to, right? So in the spirit of me not taking too long, I was going to do, let's talk about what stands out with these pictures. But I'll just talk through my thought process here, right? So there is this really amazing kids clothing line called Princess Awesome. And their whole thing is like, hey, girls can like trucks and want to wear dresses, or like boys can like pink and gentle things. Let's make clothes that fit for the kids that are in this world, right? which is great. And their website is amazing. And they're really doing some cool stuff, because if you go to any kids clothing store, like you go to like Target or Old Navy or any places like that, right? You can see visually when you walk in where the sparkles in pink are, even if they don't call it the girls section, and where all the blue, green, and camo clothes are. And so, you know, companies like Princess Awesome are really working to try to say, like, let's make clothes that fit for all kids. There's another one that I really like called Primary, who they don't even say like, here's some dresses for girls that like space. They just have their clothes. And they have all kids of all genders modeling all of the clothes. And that's a really good one to look at if you're like, no, I very firmly support all of that. Because I think for a lot of people, if you're not used to being in a space of clothes are for all people, even if you logically are like, yes, that's great, you might look at the pictures and notice some dissonance in yourself, right? And that doesn't mean that you're doing anything that's not affirming, but I think it's an interesting thing for all of us to look at and figure out, okay, so just because I have that feeling doesn't mean that I can't support this. It means that I have to like hold it and be aware of it and not let it drive the bus, or not let that feeling drive the bus. Another good way of trying to look into that is thinking about, if you just picture in your head right now, what does a woman look like, right? And then try to think through for yourself, who didn't get pictured in that image, right? And a lot of that is just going back to that place of automatic assumptions drive how we perceive our clients and how we interact with them, right? So if the image that's in your head automatically of a woman is someone with long hair, who wears makeup, who has long nails, and is wearing a dress, right? You're going to notice or have to work a little harder if the woman that you're working with in your clinic has a beard, right? Because that's not how you've been conditioned to think, right? We could also go off on this space also about how we're also socialized and have automatic assumptions around like race, ethnicity, and all of the different identity pieces. Okay, pausing for a quick second to see if there's any questions or thoughts, or if I should just keep going.
Nothing in the chat. Does anyone want to unmute themselves and ask a quick question or share anything?
Sorry, Dr. Bailey, what was the name of that second clothing? Was it Primary?
Primary. Mm-hmm.
Thank you.
And if you're looking for clothes on Primary for your kids, I'll tell you they tend to run a little small, but that's not connected to our presentation today. Anybody else? All right, great. We're going to talk about terms and definitions. Okay, my disclaimer here, fun fact, language is always changing. Use the language your clients use. Words that I use in here are going to be outdated in probably like 2 days, because that's how fast language, especially with the internet, happens, right? I'm not going to go through fine-tooth comb all the different definitions, but in case folks don't have much knowledge at all, I wanted to make sure that we went over a couple of pieces. All right, so transgender is often seen as like an umbrella term for folks who do not have a binary gender identity. So working definition, someone whose gender identity and sex assigned at birth do not correspond. And if you're wondering what is sex assigned at birth, that is the language that we use instead of like, oh, what gender was your baby when they were born, right? Because we don't actually know like biologically where people land unless we've done like a blood test and a chromosomal test. So sex assigned at birth is the process where the baby is born and the care provider looks at their genitals and say, based on this genital, this baby is this sex. And so Sex assigned at birth is the language that we tend to use in the field. Transsexual is used more in medical literature, but for folks who are also older, so often like 60s, 70s, 80s, 90s, may use transsexual to identify themselves because they feel like it fits better. You'll see that in younger ages also, but not as much. And that is a description of people who have transitioned through the use of medical interventions. So it's definitely in the medical language. It tends, I don't hear it very often. I hear trans probably the most. Gender nonconforming is someone whose gender expression is just different from how society would perceive their gender identity to dress, right? So someone who identifies as male but likes wearing dresses would be considered gender nonconforming. And then gender queer or non-binary is a person who falls outside of the binary male-female perspective. So, you know, another way to think about this in a very oversimplified way is some people feel like boys, some people feel like girls, some people feel like both, some people feel like neither. So genderqueer or non-binary might feel like both, they might feel like neither, and in a like in-between space. You might also hear somebody refer to themselves as a trans man or a transgender man. That means someone who has transitioned to identifying as male and was originally assigned female at birth. Same with trans woman, transgender woman. Cisgender or cis is the term that we use to describe someone whose gender identity and sex assigned at birth are the same, right? So I am cis. I was assigned female at birth. That continues to feel right for me. That is my identity. I identify as female. And then agender is a person who doesn't feel like they have a gender. They may say that they are gender free. So any quick questions about those terms? I see in the chat, it looks like someone says, can there be overlap with these terms? Absolutely. Some folks who identify as non-binary may also identify as transgender. And I think, you know, there can be people who are like, some days I feel this and other days I feel this, which might be more in the fluid space. I don't know if that fully got to the question you were wondering about. Yes, okay, great. All right. Okay, so this is a fun graphic called the gender unicorn that a group of folks created. This just kind of splits out. If you're somebody who you're like, I don't really get gender identity versus, you know, sex assigned at birth, how does all of that work? This just attempts to give a little bit of a graphic, right? So gender identity is how someone feels about their own gender, right? That is how you feel your gender is best represented. Your gender expression is how you communicate that to the rest of the world, right? So if you identify as female, right, there is still a huge range in how you might communicate your gender to the rest of the world, right? Some women have long hair, wear a lot of makeup, and enjoy wearing dresses. Some women have short hair, don't wear makeup, and might not wear dresses. And so it's really more where that also exists, but it's typically on a spectrum of, you know, what we think of as like feminine to masculine presenting. Sex assigned at birth is thought more of, you know, biological sex, whereas gender is, you know, more around how you feel and how you demonstrate that. And then the gender unicorn also talks about physically attracted to and emotionally attracted to. So that's some terms. Terms keep evolving. Use the words that your clients use. And the easiest way to do that is to say, hey, what identities are important to you? Or how do you identify? What pronouns do you use? And what are the words that fit best for you when you're talking about your body, right? If you're like working with someone where there's a medical context and they're having procedures, it can be helpful to know what those words are. Other ways to work on affirmative care is just having some visible signs and statements of support in your agencies. So that might be a sign on your website or on your door that says all are welcome here. It could be part of your mission statement. It could be verbiage across places that just note all are welcome here. You might choose to have the progress flag up in different places. You know, any of these help. It gives that visible signaling to other people of like, oh, at least one person here has some awareness to have these pieces up, right? And that can be helpful and just decrease some anxiety for our clients. All right. Other things that we want to look at in thinking about what are we visually showing to folks in the community, right? Check your forms, check your signs. So if you don't have intake forms that ask everybody for their names and pronouns, it is a visual signal that your agency isn't as aware of how to be affirming, right? It doesn't mean that you're not affirming, but it's a signal. And a lot of times trans folks are looking for those signs, right? Am I welcome here? Am I going to be seen here? Or am I just going to have to like deal with a lot of yuck to get the care that I need, right? And when folks have a choice, like this is true for all of us, right? If you have a choice to go to a place where you're going to be seen as yourself, you're going to actually get the care that you need, and you're not going to have to like put up with a bunch of fuss, you're going to choose that place, even if it's harder to get to. It looks like there's several folks that are asking.
Can I just make a quick comment?
Yes.
I think it's really important. We sometimes fall into the pitfall of putting stickers up without really confirming that everyone in the space, in fact, is inclusive and knowledgeable. And I feel like it can sometimes be even more damaging to have the perception or the expectation of a safe space and then, being mistreated, misgendered, mispronounced, etc. So that I feel like that second step of having a workforce that really knows what they're talking about is really important for those stickers.
Absolutely. And towards the end of my talk, like part of what we actually talk about is it's not enough to just say that you're doing the things, right? And it's not enough actually for just one provider to be inclusive and affirming, right? Because then there's still a lot of steps that people have to go through to get into that provider's office. And so really the gold standard is, can you have everyone that a client or patient is going to interact with be at that level of affirmative care, right? Because what we want is for our trans and gender expansive clients to feel like they get to just be people coming to get taken care of, where they can ask what they need to ask, talk about what's hard, and not have to also experience harm in the process. And so all of these pieces are small steps of how to do this. So thank you for that comment. That's absolutely right on. So some of the things that we can do, right? We want to make sure that we're asking everyone for their name and pronoun. And we want to have space on all of our forms to note how someone wants to be addressed, right? And so what I mean by that is, plenty of trans folks have been through a name change process and their legal name is the name that they use. And so they only need one spot to write their name, but not everyone does. And so having space where we're asking everyone, what is your name? What pronouns do you use? And then an additional space, what's your legal name? And some forms might say, what's your chosen name? Or just name that you use, name you go by. those are important things to have, because if the only thing that's there is legal name, right? And a lot of places, if that's someone's legal name, you have to have that in your documentation if you're billing for insurance, right? So having those two things separated out and a way to communicate to everyone that the person might interact with which name to use and what pronouns to use is helpful for staff so that they use the right name and pronoun. It's also helpful for the client to see like, oh, okay, I get to put this here, right? And once you know what the person's name is that they use, you don't need to know if there's you don't need to use their legal name, right? And you don't need to ask them, unless it is relevant to their care, anything around how that process went for them.
Melissa, can I ask a quick question?
Yeah, go ahead.
So we are having a incredibly difficult time at our clinic finding an EMR that allows for this.
Yes.
Right now we have this very convoluted process where instead of a middle name, we put the pronouns and the other, and it's not great. And it's sort of the best we can do for them. I was wondering, first of all, if you happen to know of an EMR that is more inclusive. I guess that was my first question.
Mm-hmm.
And then my other question, sort of separate but related, is piggybacking to with the last person. I'm not sure who made that comment about the stickers. We're having similar issues in our clinic where not everybody who signed up to sort of work, especially our front desk staff, we were originally just a medical clinic and we recently opened a queer only health clinic, and not everybody signed up to do that.
Mm-hmm.
And not everybody's that excited about it. And our take has basically been, well, sorry, this is a job requirement. So, you got to do that. But we're also trying to find ways to really sort of support people while they're figuring out how to negotiate that.
Mm-hmm.
So now I'm asking two separate questions, one about an EMR and one about if you happen to have suggestions as to what we can do to sort of ease that process, because we're having some challenges.
Absolutely. And this is one of the challenges, right? Like, I work at a queer health center and we get people who want to come work with us because, we're near their house, right? Or we heard you do good work, we want to work at a good place. Whatever the reason, but they may not have any knowledge of how to work with the communities we serve. So it's the same challenge, right? And people it also goes back to that automatic assumption space, right? There may be people who are like, absolutely, I want to be affirming, and then doing a bunch of stuff that's hurtful and they don't even realize it, right? And then there's just the outwardly hostile. So EMR wise, the current EMR that we use also doesn't really have a great system. We have a space for preferred name. And so when a person's chart comes up, it lists their legal name, and then next to it in quotes, it gives the chosen name, the name that they use. And then we do it's called a care alert that pops up. So anytime you open their chart, it pops up and that's where we list pronouns. Okay. Because when we send mailers out, it's set up so that the name that people use will end up being the name that goes on the mailer. But if we add the pronouns in that section, the pronouns end up going on a person's envelope also, which is awkward. So it's a pop-up alert that lets you know about the pronouns that they use. We are about to switch EMRs, and so I don't know how the new one does it, but I think that's a universal problem that the EMR industry needs to fix. Yeah,
we've been looking to switch ours, and we haven't found anything that seems any better. I was just hoping maybe you knew one.
No, I think all of them have different levels of difficulty.
Sure.
But hopefully that'll keep moving. For the second one, I actually would recommend that you as an agency figure out what is additional training, and people who complete that training get the sticker. Right? So here's baseline required training for everyone on how to do this, why we're doing it, why it's important. And then if you would like to be eligible for these other pieces, or you want to signal that you have some advanced training, here are the pieces that you can do. and then you get these extra pieces, right? Because that way it's it's saying everyone must do this, but if you want to do this, you got to come up here. You got to have more training.
Yep.
And then that can allow some opt-in in a way that I think can allow staff that are opting in to feel more in control of that. It can also help identify if folks are like not opting into that, well, you don't have to, and here's how to separate out those pieces. Where I work, there are plenty of people who come in without a lot of trans experience also, and so we have baseline training that everyone goes through, and then anyone who is joining our behavioral health department does additional training just to learn more about a lot of the medical aspects, different language and terminology, because if you've got clients coming in who are doing some medical transition pieces and wanting to talk about it, you need to know what those things are and be able to have conversations in ways that demonstrate what you're talking about. Because I think so I would go that way, and then it's not punitive. I think often the more punitive it gets, the more people dig in.
Yeah, makes sense. Thank you.
Yeah, you're welcome. All right, y'all can read, so I'm gonna keep moving forward. All right, so self-determination is one of my favorite things to think about in affirmative care. And I'll do this piece, and then it looks like a couple of folks I got a chat notification that there's several things in the chat, so we'll pause and see what that is. So really kind of broadly, self-determination means we believe trans people. It is that transgender, non-binary, gender expansive folks, they get to self-identify without proving that they're trans, right? So we're not policing someone's gender. The easiest way to think about this is if a new client comes in and you're like, hello, how are you? What's your name? Blah, blah, blah. And they say, I'm trans. You say, awesome. What are your pronouns? Thank you for telling me, right? We're not going to have time to go into the history of trans healthcare and where it started. Normally I do that at the end, but for a long time, there has been a thread in the mental health and physical healthcare spaces that we need to make sure that people are trans enough before they get to do any sort of accessing gender affirming care, right? So we just need to come from a place of self-determination. If someone says they're trans, we believe them, right? Just at a baseline. And then if they want to explore gender and they want to talk about different things, or they're like, I can't figure out what pronouns work for me, awesome, that gives us a place to start. But often this idea of let's make sure this person actually knows that they're trans and are actually sure, right? Having someone prove their gender really goes back to that place of believing that trans folks are mentally ill or sick or wrong, right? And there's some threads that connect to that there's this idea that all trans folks are people with horrible dysphoria who believe they were born in the wrong body, right? That's true for some people. It's not true for everybody. And so you may have trans clients who are like, oh yeah, hi, my name is this, my pronoun is this. No, I don't need any medical access to transition. Like I'm good. I'm good where I'm at, right? And we get to just respect that and celebrate that with that person. And I note that because I think oftentimes people get really focused on, okay, so this is a trans client and we use the right name and the right pronouns. Okay, now I need to figure out what transition support they need, right? And a lot of folks aren't coming in because they want hormones. They're not coming in because they want surgery. They might be coming in because they're depressed, right? Or if you're also at a medical clinic, they might be coming in because they have a sore throat, right? And that is unrelated to their gender identity. And so really coming from a place of we believe trans folks when they tell us who they are, like that step more than any others can really do a lot of good. All right, I'm checking the chat really quick. Oh, these are folks are saying Athena is one, Epic. Sounds like a lot of people are saying Epic's good in name and pronoun pieces. All right, so what are some barriers to self-determination? Well, that's coming in when a client's like, hey, I think I'm trans, right? Questioning someone's gender. Anything that gives the impression that you're like, I don't know, are you sure? Those are things to skip, right? Now, if you're doing therapy and someone's like, I think I might be trans, right? That might be an open space for conversation, right? But there's a different way to say, tell me more about that. Or what led you to that space? Or how would you like us to talk about that in here, right? Those are questions that open up conversation. Asking someone if they're sure shuts down conversation, right? Because that's communicating, I don't know if I believe you. And that it may have taken a lot for the person to share that. Another barrier, asking a client for their dead name or insisting on using that because it's the legal name. If you don't know what dead name means, it is essentially a legal name of a trans person that they don't use or identify with anymore, right? For clients who have a chosen name that is different from their legal name, or a chosen name that is now their legal name because they have legally changed their name, right? If you have someone who has done a legal name change, you don't ever need to know what their old legal name is. It's not relevant to their care, right? If they're doing transition pieces, you might say, when did you change your name? But you don't need to know what their name used to be because that's not their name. Just use their name. Another one that I feel like isn't happening, I'm not hearing folks talk about it happening as much, but oftentimes because people, if they haven't worked with a lot of trans folks, sometimes they get curious or they want to show that they know something. And so sometimes a question that comes up is like, hey, so have you had the surgery yet? And for folks that don't know a lot about surgical transition, there's a lot of different surgeries. And so instead of signaling like, hey, I know something about this, it actually signals like, I don't know, and I'm asking a super personal question, right? Because when we boil that question down, we're asking someone, what kind of genitalia do you have, right? And I'm assuming that most of us don't go around asking, our friends that question. So, these are things that are going to just like shut down the conversation. If someone comes in and they're like, oh yeah, I'm not on hormones. No, I don't really need that to feel, right for me. That should be enough. If we get stuck in the, why don't you want that, right? We're not asking, how can I help you? What are you needing? And those are some pitfall areas that a lot of trans folks say, like, these are the things that come up a lot that make going to get care hard. It's hard to deal with how to navigate any of these questions because even if they're coming from a well-intentioned place, it's still putting the work on the person instead of a provider coming in and saying, how can I best help you? All right. So ways that we can overcome those barriers. The biggest one is use inclusive language. And this is something that works really well. We just got to practice it. So inclusive language, right? It's not making assumptions about people's gender. So if you are a greeter at your agency or you've got folks that like welcome people and help check them in, right? It goes a long way if they greet everyone with good morning instead of hello, ma'am, hello, sir, right? Or if you're going to address a group, opening that with ladies and gentlemen is already inviting gendered language in, right? But if you open a conversation with, hello, everyone, I'm happy to see you, right? It's inclusive. It works for every single person. that might be in that room, regardless of how they identify, right? Another one, you know, instead of saying, oh, go ask the checkout lady over there, right? Go ask the person who's checking people out. And then the last one, if you don't know how someone identifies, use they, them until you can find out what their pronouns are. So a lot of folks say that gets kind of funky and they have a hard time thinking about they. And I think because going back to the, you know, automatic assumption piece, like our brain, if they see someone with long hair, right? Or someone with breasts or someone in a dress, like our brain wants to say she, our brain wants to say woman. But we all use neutral pronouns already. It's just once you add in a visual component, it makes it harder. So this is one of my favorite little blurbs that social media has brought up. So just found a wallet on the ground at Macy's. I found the cashier. Together we tracked down the owner. They were so happy that I returned their wallet that they tried offering me cash. Of course I refused because it's not their fault that they lost their wallet. Anyway, the moral of the story is you do understand how to use they, them pronouns to refer to a singular person. You do. And so does everyone else, right? I think for most people with exercises like that, you don't notice the non-gender pronoun until you get to the end and it's raised for you, right? And I think it's a really simple way to demonstrate that, like, we know how to do it. It's just once there's different input also coming in, our brain wants us to do something else. And so we just need to practice and practice and practice until it becomes so normal that it doesn't feel different. Okay. Oh, geez, we only got 10 minutes. All right, here we go. Trying to get through it. So affirmative care throughout a person's visit. Another way to think about how do we do this is how do we have a harm reductive perspective in our agency, right? Harm reduction tends to mean that we're using a collaborative approach with our clients and patients. We're asking for permission before we do certain things, right? Another way to be harm reductive and working with clients is to be mindful in our paperwork, right? How do we be mindful? Well, if the client uses a neutral pronoun, right? Check your paperwork after you do your notes and make sure that their pronouns are correct, right? That goes a long way. If you're not sure, consult. The more that you reach out to other people and say, how do I do this well? The more our clients are going to benefit. Have a system so that every point of contact at your agency knows what the client's name and pronouns are, right? And then I put in here, you know, remember to think about systemic oppression and safety. You know, I work at an FQHC. I'm sure a lot of you also work in agencies where you're trying to provide services to folks who otherwise wouldn't be able to access it, right? So in thinking about just the different ways that systems are set up and make all of this harder, right? The more that we can try to show up across the board for folks, the better their care is, and the more affirming we can be. So what does that mean specifically? What are specific tasks that we can do or we can train folks at our agencies to do? Introduce yourself with your name and pronouns every time, right? Even if you identify as cis and you read cis, if you're introducing yourself every time with your name and pronouns, it is signaling to anybody that you might be encountering who's trans and gender expansive but may be worried about how to talk about it. That signals that maybe you're a safe person, right? If you're asking everyone for your name and pronouns, you're more likely to get that information from the folks that need it. Instead of saying to someone like, oh, use they, them, are you trans? Right? That's gonna, instead, hey, for everyone, what identities are important to you? And how does that show up in your care? Like, how can we make sure those are seen? Right? Because even if someone is trans, they still may have other identities that are important. And if that's going to open up conversation space to give them the best care possible, then that's a win-win across the board. A lot of times people can get stuck in this idea that a trans person's only coming to therapy because they need help related to their trans identity, right? Asking someone who's come in that identifies as trans, that's like, yeah, I'm here because I'm depressed, asking how do the pieces intersect goes a lot further than how much of that is related to being trans, or just making the assumption that all of their problems are related to their identity. That happens a lot. And sometimes folks are trans and they have depression, and it's not necessarily connected to gender dysphoria, right? Ask someone what support they need. What are their mental health goals? What are their treatment goals? Or even if someone's like, yeah, you know, I've realized that I'm trans, and so I figured I should come talk about it. Great. What would your goals be around, you know, working through your gender identity in here? Because if we go in with the assumption of like, oh, yes, of course, let me get you what you need so you can get hormones, that's foreclosing on their ability to say what they need. And anything that's going to close down conversation, as we all know, makes it harder. I thought I saw a thing, so I don't think that was for me. Oops. All right. And then if you hear somebody using terms and identities that you don't know, find some good resources. They're listed at the end of this PowerPoint, of places to look up and figure out what do those things mean. And it's okay in the moment to say, hey, I don't know that word. Can you give me a quick snapshot? Because I don't have time to go look it up before we keep working, right? So what's our role? Respect your clients' identities. Teach ourselves the knowledge that we need, right? What are the terms? What are the identities? What are the language? How is it changing? Get a buddy at work and be like, hey, can we practice doing this and charting together on a fake client that uses this pronoun, or how to note these pieces around someone's identity? The more you practice it when you don't have a client, the better you're going to be at it once you do. And then, you know, the last piece is figuring out what is the difference between someone coming in because they need to do an assessment because they need access to transition care, or they're coming in because they want therapy for a mental health concern. Some clients are going to come in because you might live in a state where doctors aren't going to prescribe hormones unless they have a letter from a therapist, right? Or this person is coming in because they want to have gender affirming surgery and they need a mental health letter for that. So people might come in because they just need a letter. That person's not coming in for therapy. Those are two different services. And you don't necessarily have to do both. You could say, this is what we offer, or, you know, I don't think you don't have to have therapy to make sure that you need a surgery letter. All right. This is the big one. What do I do if I make a mistake? I feel like the majority of people that I work with and train in affirmative care, the biggest place that they get really worried about is like, okay, I believe all of this and I'm working really hard, but I'm so worried that I'm going to hurt someone by making a mistake that I feel kind of frozen, right? That's fair. So I've found that sometimes talking about how do we do it well, right? Because often what happens if you use the wrong pronoun, we get flooded with like, oh no, I just did the hurtful thing. And then we end up like, oh my gosh, I'm so sorry. And like over apologizing in a way that can be overwhelming, right? If you make a mistake and you notice it, pause, correct yourself, apologize, and then move on, right? If you don't notice it and someone else calls your attention to it, right? If you can build a culture at your agency where if someone uses the wrong pronoun for a person, it's okay for anyone around to share the correct one in a lovingly respectful way, right? If you get corrected, acknowledge that you made the mistake, thank the person for correcting you, redo it with the correct pronoun, and then move on. If you don't know what a word means, it's okay to ask. Oh, I see that you use a pronoun, you know, ZIR. I haven't seen that one before. Can you pronounce it for me so that I say it correctly, right? Or, hey, I'm looking at your paperwork in front of me. You know, how do you conjugate this so that I can use it correctly? It's okay to ask that. There's also a website that I've got listed later on that shows like you can type in a pronoun and it'll conjugate it for you so you know how. Be a real person, right? If you mess up, acknowledge it, show humility. You don't have to have all the answers. Practice. Also, work on having a life that includes people who are different from you. If you don't have trans people in your life outside of work, you know, what would it be like to broaden your environment? Because that's only going to help your care.
Really quick, Dr. Bailey, Stacey had a question in the chat about writing letters. Do you have any guidance for just a few moments or for ongoing training for clinics?
Yeah, so I do offer like a 3-hour, here's how you write surgery letters for folks. I think the next one I'm going to do is probably going to be in March or April. And, you know, the basic gist, I've got a couple slides. I'm going to skip forward if that's okay, because I know we're totally out of time. And I will send these slides on so that folks can read them. So
thank you, that's great.
Absolutely. So biggest things for surgery letters for someone who needs surgery access, you should know that the client needs to have a diagnosis of gender dysphoria for insurance to cover it, right? We shouldn't give that diagnosis to everyone just because they're trans. We should use it if it's appropriate because that's what they're coming in for, or because they meet that criteria and they're going for surgery letter, right? Because being trans is not a mental illness. So we don't need to use it unless it's for surgery. We're going to skip that. Oh, I will say if you're writing surgery letters, a lot of people are like, well, I don't know the person well enough. They need to have therapy with me for a while. Gold standard currently in the field is you should be able to do that in one appointment, right? It's not a 30-minute appointment. It's longer than that. Because really the biggest thing that you're assessing is informed consent. Can this person provide informed consent? There's other pieces that you're going to want to assess, right? And obviously if a person has like a really extensive, complicated mental health history, you're going to need a longer assessment period. But for the majority of folks, you should be able to do it in one appointment. So the biggest thing that we're doing is assessing informed consent. So we're looking at what's their decision-making process. How do they bring in information and make sense out of it? And what is it that they're looking for, and how are they hoping life will be better after surgery? And are they aware of the steps that they need to take before and after surgery to take care of themselves so that they have good results from surgery, right? Can they take information from a surgeon and follow those directions and understand why, right? So to write a surgery letter, you are assessing basically, can they give informed consent? Is the surgery medically necessary? Does the person meet criteria for gender dysphoria? And do they meet the criteria outlined in the WPATH standards of care? WPATH stands for the World Professional Association of Transgender Health. They are the ones that set the guidelines that all insurance companies use. So right now we're on version 7. Public comments for version 8, I think, just closed. I need to update that slide. So, you know, I'm going to skip that. Version 7 is the most informed consent base that we have so far, but it's still got some ways to go. These are the requirements that WPATH someone says that a person needs to have. They need to have well-documented gender dysphoria. Most insurance companies interpret that to mean they need a diagnosis in a chart. They need to have been billed for gender dysphoria at some point. Capacity to make informed decision and capacity to consent for treatment, right? So do they know what they're asking for? And do they understand the risks? Age of majority in a given country, that can be 18 in some, it's 21 in others. If a person has significant medical or mental health concerns, they're reasonably well controlled, right? Reasonably well controlled might mean this person has a generalized anxiety disorder, and the way that it's controlled is that they go to therapy, they take medication, and they have a sense of what coping skills work for them, right? It does not mean that someone needs to have crystal clear mental health. No one has crystal clear mental health. Everyone struggles sometimes. 12 continuous months of hormone therapy as appropriate to a person's gender goals for certain procedures. If you have a client who would like to have top surgery and they identify as non-binary or trans man, and they would like breast tissue removed from their chest, you are not required to be on hormones for that. If someone would like to have breast augmentation, where their breast shape is increased in their chest, they do need to be on hormones for at least 12 months for that. The easiest way to think about why is some hormones are going to provide different changes to a person's body. Starting estrogen increases breast tissue growth. If you get implants, breast augmentation, before your body has grown as much breast tissue as it is able to grow on its own, you might end up with a larger size chest than you would like. So surgeons ask, be on hormones for at least 12 months. Let's get the most out of the medication before we go to surgery. It ends up having better outcomes that way. You need 1 or 2 mental health letters for the surgeries. Anything that is changing your genitalia, you are going to need 2. And WPATH specifies that at least 1 needs to be from a person with a doctorate. You also will need a letter for any of these surgeries from your primary care provider. WPATH also lists out what clinicians need to be able to demonstrate to show that they are qualified to write these letters and make these determinations. And so if you haven't done any training and you send one in, it could get flagged for that. So I want to make sure that the people that are working with clients around surgery access, have some knowledge, because that's better for our clients. All right. So the rest of this talks some about some trans healthcare history and where it comes from. I've got some resources that you can look up and then some references. All right. Whew. Oh, that last slide was supposed to say thank you. What questions do you have? But I'll leave it here instead.
Thank you so much, Dr. Bailey. Are there any last questions or thoughts? You can always share any last questions with me. Kelly, I'll put my email in the chat, and I can always feed those on to our wonderful colleagues at Howard Brown. We will work on making the recording and the PowerPoint slides that Dr. Bailey is so generously sharing with us available. And when those are available on our SIG landing page or another place that's appropriate based on what CFHA shares, we will let everyone know on the listserv and let people know who registered. These are great resources. Thank you so much.
Absolutely.
Great.
Happy
Well,
to
thank
be
you
here.
thank you so much, Dr. Bailey. This was a really wonderful presentation, and I heard so much in the chat, just lots of really helpful reminders and really great guidance.
Great. Thank you. I also just put my email in the chat. It's melissab@howardbrown.org. If folks have more specific questions, or you're like, oh, hey, I would love to go to a training on how to write letters next time you have one, email me, let me know. At Howard Brown, I also run a consultation group that meets monthly on trans affirmative care for mental health professionals. It's full for this next round, but if that's something you're interested in down the road, we also have an early career clinicians one that's starting, I think, in February. And then we also just offer some other trainings from time to time. So, reach out if you want to get added to my, not official email list when I'm like, here's the stuff. Or if you have more questions and want to talk, more offline. Happy to.
Great. Thank you all so much. Take care, and we'll keep updates coming, and have a great day, everyone. All right.